So thanks a lot, Marius. Up to you.
Thanks a lot, Matthias, for those very nice words. I didn't realize that I did all of what you described. It was really, really kind of you, and coming from you especially. Okay, so I took the deliberate decision. I wanted my presentation to be complementary to the one of Neil, because my work in the last few months has considerably evolved and has completely transformed. From being primarily a data analyst, like doing research, to doing something that is completely different, which is communicating about important results and communicating into a very useful way so that people can figure out what is at stake. And also talking to politicians and to decision makers, and both have their respective challenges. And I wanted to share a little bit of the experience that I have acquired in this through this talk. So I'm going to share my screen and so that I can share my slides with you, and those will be made available after the talk. So I hope you can all see my screen. If not, please shout, but I would assume that you're seeing this. So just a few words of introduction beyond what Matthias said, because I think the spatial epidemiology for many of you, it's a bit obscure of what it may represent. So what we do, we trying to understand the distribution of disease and vectors in space and time. And primarily in space, and that's why we call us spatial epidemiologists. And to do that, we approach it through different themes. One is statistical modeling and spatial modeling. Another angle is what we call host mapping, doing global maps of where the hosts are and in what kind of host they are. And a third theme of our research group is phylogeography, that is led by Simon Delicourt. So very briefly, the typical kind of outputs we do in the spatial modeling is what we call risk maps, which are a very useful tool to communicate with decision makers because they allow pinpointing areas that are at particular risk of transmission. And this is, for example, a risk map that we had published on the distribution of avian influenza H5 and 8 in 2016. And this is a very useful tool for communication with decision makers, as I said. But behind those fancy maps, you have lots of quite tricky modeling and statistical modeling that is involved. The second kind of things we do are mapping distribution of hosts, people and animals, because lots of emerging infectious diseases are emerging at the interface between animal and human. And the third kind of work is the work led by Simon Delicourt. It's about trying to reconstruct the spread of epidemics from the genetic data that you can obtain from different sequences that have been sampled in space and time. And this is an example of some phylogenetic reconstruction of the Ebola epidemic in Western Africa that was led by Simon. So that's the three types of work we do. And for a long time, we've been interested into those emerging infectious diseases that are appearing at the animal-human interface. And to a large extent, SRAS-CoV-2 really perfectly fit that set of disease. It has emerged at a certain point in time in China at the animal-human interface. It's not yet entirely clear where and when this initially took place. But this is really this is not atypical. This is something that we have been studying for many years. And for all of those events, you have three major steps that are indicated here in those three columns. So you do have first the local emergence. That's what happened apparently in Wuhan in the late of 2019. Then you have international spread, and then you have local epidemics and endemicity where this is taking place. And for each of those steps, you have different risk factors that goes with them. You have different set of preventive measures, and you have different sets of reactive measures. So when you're talking about local emergencies, you really want to study the animal-human interface. You want to see how you can reduce the interface between animal and human. You can do some early detection in those areas of emergencies. And if there is an emergence, you can try to aim for the early detection and early eradication before there is any spread further away. And then you have the international spread, and that the main risk factor for international spread of human infectious diseases, of course, human mobility. And for that, you can prevent that through increasing your detection capacity, and you can prevent it through traveling procedures. But once it starts spreading internationally, it's actually very difficult to fully prevent it, and you can try to slow the spread, but that's really as much as you can do, especially with a disease like COVID, where there are some asymptomatic cases. And then when it starts spreading internationally, you have some local epidemics and sometimes local establishment and endemicity. And that's primarily driven by individual susceptibility and contact structure in the areas where those pathogens are introduced. What you can do as preventive measure is pandemic preparedness, protective equipment, and diagnostic capacity. And this is really a field where, to a large extent, many European countries have failed with this pandemic. And you can also have reactive measures which aim to reduce transmission and with time, the development of vaccines and different therapies. So in the last decades, there's been a number of those emerging infectious diseases that are not well known to the public in general. Of course, there was SARS-CoV-1, which was a bit more serious in terms of fatality rate than SARS-CoV-2, but it made the jumps from animal to human. There was some local cluster and local epidemics. There was a bit of international spread, but it was more quickly contained. And then there's a number of other emerging diseases that you may have heard of, avian influenza H5N1 and H7N9, swine influenza H1N1, Ebola, the Middle East respiratory syndrome, Zika, and then SARS-CoV-2. And of course, not all those diseases are equally fatal. For example, H7N9 was highly fatal, but it only made the jumps from animal to human. It circulated in China for 5 subsequent years, caused several hundred cases and death, but it never made it human to human. So it never led to local cluster or local epidemics. And only some of those emerging pathogens make it to human transmission, then international spread, and eventually to widespread distribution or pandemic. So I wanted to say here is that SARS-CoV-2 had many predecessors, and much of the work we've been doing has been focusing not so much on the spread in humans, but more at the animal-human interface. And that explains why the focus on livestock diseases is important. But that's more to explain where I'm coming from in this epidemic. Now, as I explained earlier on, initially, as I described, our lab is mostly involved into doing analysis. We do statistical models, we do predictions, we do risk maps. And until January and February, also on SARS-CoV-2, my role was mostly research. I was doing a little bit of communication in the early stage and virtually had no role in policy. But then came the lockdown that started in March. And then I shifted my activity and energy and effort to communication, to try to provide a clear communication to the public through the media in general, but also through Twitter. So those two tools were really complementary, because I could explain things when I was talking to the media, but Twitter allows you to give a little bit more elaborate content, allow to share some graphics, allow to share important publication at the time. So it was a very useful tool to communicate with the public in a more in-depth way. But I was at the time not involved in policy. And then from April through September, I was first involved in the group of experts on the exit strategy, the GAZE, where Matthias was also involved. And then my role really shifted toward more policy, trying to communicate with policymakers, trying to think of how we could get out of the lockdown in a safe way, and with much less focus on communication, simply because I didn't have much time for it, but also because there was a bit of a conflict in the nature of the work. You couldn't, on the one hand, participate to the decision and at the same time being very active in communication without creating a tension between the two. And then, of course, my research, I couldn't do any research for all of that time. And now I'm at a time where things are a little bit more balanced. So the goal of this presentation is really to try to share with you what have been my main insight in terms of how moving from research to communication and policy has completely transformed the way I worked and interacted with others. So let me try to summarize the main difference that I can see between my conventional role as researcher in epidemiology with what you have to do when you move in real time. So the first difference, of course, is that usually we most of the time we work retrospectively. So we work on past epidemic and we try to gain knowledge based on the data analysis of those past epidemic. And in contrast, real time, by definition, we're working on the fly. We received data day by day, and we asked to analyze those data day by day to inform decision making. And the objective becomes completely different. Conventional epidemiology, the primary objective is to gain knowledge about disease, about transmission patterns, about preventive measures, what can be useful or not. But in real time, the main objective is to inform decision makers, inform the public, inform the media, inform stakeholders on what's happening, and trying to explain what is currently happening. But there's a really major difference here, is that your recipients are completely different. When you do conventional epidemiology, you're speaking to other scientists, and those other scientists have a similar background as yours. So you disseminate, you talk to them in conferences, you communicate with them through scientific papers, but you can assume a common understanding of things. With real-time epidemiology, well, you're talking to the lay audience, to the media, you're talking to journalists, you're talking to policymakers, and they don't have the same background as you, sometimes even on the most basic biology that's behind it. So you cannot assume any kind of knowledge or common understanding with people you speak to most of the time. Dissemination goes through media and through report instead of conference and scientific papers. And of course, when you do real-time epidemiology, you cannot count on the quality check of peer reviewing. That is the normal way of ensuring the quality in science. You just, you're working without nets. If you make a mistake, the mistake is there. You don't have someone who accepts others if they see mistake you're doing real time, but you're a lot more exposed to mistakes because of that. And the fact that you're doing things real time has a lot of implications. The real-time aspect is that first, by definition, you have little time to analyze your data. So you have to automate lots of what you're doing if you don't want to redo things every day. Most of the time, you working with incomplete data set that keeps becoming transformed in terms of format, in terms of how they are organized, where you have to get your data from. And there are, of course, problems of data access. And we've been confronted to lots of problems of data access throughout the epidemic. Then in terms of, because the objective is different, there is a major implication is that what you find or decide or recommend can itself influence the course of the epidemic. So if you are able to identify specific risk factors or specific areas of transmission, well, in turn, you can act on the epidemic itself. So in contrast to retrospective analysis. So the responsibility you're having in your outcome is much, much greater because it's, well, you can really have an impact. And that's for the good, but it can also be for the worse if you're not careful. So this implication of a lay audience is that, as I said, there is no shared understanding. And the second aspect is that you keep being challenged by what I call armchair epidemiologists. So people who just got for the first time their hands on numbers and who keep challenging you about what you're saying or stating. And that creates lots of confusion. And I will get back to this. Finally, two other elements. Because you're disseminating through media and report, the quality of the communication becomes sometimes more important, even more important than the content. You have to communicate very clearly, and this influences the way you choose your graphics, the way you choose your words. Quality of communication, sometimes it's much, much better to convey few messages that are well understood to try to convey complex messages. And that really, for us scientists, is really a challenge because we tend, if you go to, we tend to, how to say, we're interested by complexity. We know that we're dealing with complex problems, complex systems. And when we do research, we're trying to balance the complexity of those systems. We're trying to reduce the complexity of those systems to a few testable hypotheses, but we are aware that they are part of complex systems. When you communicate, you have to be very careful, and you don't want to give a simplistic message, but at the same time, the message has to be understood. So it's really challenging to make the message easy enough to make it understood, but at the same time, not making it simplistic or make people believe that things could be easily solved, because it's a complex problems by nature. And finally, because it's real time, you don't have the quality check of peer reviewing, so you're more prone to errors. So in this talk, I'm going to spend a little bit more time on two aspects. The first aspect is the fact that you have incomplete data, the problems of data access. And the second aspect, because I think for me that's the most important one, is this notion of no shared understanding. So on this first aspect, I only have one slide, just to say that in the very early stage, in the beginning of the lockdown, I was at the time copy-pasting values I was getting from the Cienzano report because the data were not public at all. So every day, every morning, I was entering the latest number of cases, hospitalization and death in an Excel worksheet, and then making a few plots to be shared on Twitter with those numbers. And very quickly, that becomes completely absurd given the importance of this disease for society. And there was a public call for open data that I strongly supported. And the call was heard to some extent by Cienzano, and they provide a series of baseline data sets, and they put those data sets in the public domain. And that was important as a breakthrough, because from that moment onward, it was possible at least to have some kind of automated analysis of the cases, hospitalization, and death and admission in ICU. But of course, the number of data sets that they provided in the open was quite limited. So they only provided access to baseline data sets. And if we wanted more detailed ones, it was actually quite difficult. So it's only through my position and Neil Henn's position as member of the GIS that we were provided access to some more detailed data sets that were held by Cienzano with very, very strict data access and sharing policy. And when I'm saying very strict, it meant that we couldn't communicate any of our output with third party without Cienzano's authorization. So we could only use them in the context of our conversation with the government and within our activities with the GIS. And in the first version of this, we could only, we had to get the approval of Cienzano first. And at least we managed to have some relaxation of that, because it was making our life impossible. But those conditions of access to the data were really strict. And it raises a very important question, I believe here, is that the way Cienzano has been working through this is the conventional way. Of course, if you do retrospective analysis, when you do conventional epidemiology, it's perfectly fine that, you know, if you want to access data that are collected and maintained by Cienzano, that you make a project, you describe what are your data requirements, you submit this request to Cienzano, and then they look at your requests, they evaluate the benefits, and then you can agree on some conditions of co-authorship, etc. And you get a procedure for you to get access to those data. So this is perfectly fine for conventional epidemiology, because those analyses are retrospective and you're not pressed by time. But in this context of this epidemic, which had a massive impact on society, those rules and regulations looked completely absurd and completely bizarre. And lots of scientists complained about the fact that they could have helped society with useful analysis, but were simply not provided access to detailed data sets. And that, I think, it raises a very important point on, you know, when we are in crisis time, you know, how could we better work to make data available to support decision-making and reactive analysis. And a third way to have more information from Cienzano was, of course, to pressure them to integrate some more analysis in their daily reports. And so there was pressure that was made, for example, from Bernard Rentier, who insisted during the summer to have more data on the positivity rates, and those were but included in the report. So there's a real issue here on what differentiates real-time epidemiology from conventional epidemiology in terms of who and under which conditions can different scientists have access to detailed data about what's happening. So now I'd like to get on this second point, which is the fact that you're not talking to scientists anymore, you're talking to journalists, to policymakers, and to lay audience. And this notion of no shared understanding, because it has lots of implications. First example, this was an example that I took from early in the epidemic. On the right-hand side, you can see a map of the number of cases by municipality, and the circles are proportional to the number of cases by municipality. And of course, when Cienzano was making this map available to the public, and then I realized that a lot of the people were asking, but why is there more cases in Flanders? And of course, to an epidemiologist, it is quite obvious, because for epidemiologists, we know that where you have more people, by definition, in absolute term, you're going to have more cases. And so I simply grabbed from somewhere a map of human population density and put two maps next to each other to say, okay, at this moment, there is more case in Flanders because there's more people in Flanders. And that's simply, what you would expect. If there is an equal incidence everywhere, you expect more populated area to have more cases in absolute terms. And that's obvious. But it made me understand that what was obvious to me was not necessarily obvious to everyone. And there's the second element that is not shared by the greater public or by politicians, is that there is a difference between what you measure or between what you observe and the reality. And the best example of that is the difference between what has been a case in the early stage of the epidemic and what is the case now and what was a case in the summer. During the first wave, only people who had severe cases were tested. So it was only the people who required hospitalization. So the number of people who were tested only include essentially the severe cases and the deaths. But we all know that in epidemiology, well, especially for these diseases, that you have more deaths than you have severe cases, and you have more severe cases than you have mild cases, and that you have more mild cases than you have positive people by PCR. So when the case definition was changed early May to include mild cases, people who would simply do clinical symptoms, by definition, even for a constant circulation of the virus, you would have an increase in the number of cases. And that's not because there are more cases, it's because the definition of what is a case changed. And then early June, there was another change in the case definition to include high-risk contacts and also to include returning travelers from other countries. So here again, you were testing people who were more at the base of the epidemic pyramid. So here too, by definition, you would have more cases, even if the epidemic had been at the same level. And of course, this led to an increase in the number of cases that was not matched by an equivalent increase in the number of hospitalizations. So this plot here shows you what was the status of the number of cases on the left and the number of hospitalization until late September. So, of course, the media, they were picking up the left-hand plot and they were saying, and rightly so, we seeing more cases now, and we seeing as many cases as there was before. And then for all who were somehow, well, many other scientists started criticizing this rightfully, saying we're not representing the same thing. Because of course, if you consider that the case definition changed, what you measured in July or in August or September is by no way equivalent to what you measured during the first wave. And of course, the plot of the hospitalization was a much, much fairer representation of the reality of the underlying transmission, which was that there was indeed an increase of the number of hospitalization in late July, early August, followed by a reduction and followed by a modest increase at the time of the number of new hospitalization. But from an epidemiologist point of view, that's not even an issue. For me, in my discussion with Neil Hens and with others, this was obvious to us. We didn't need someone to translate us to us. But it created massive confusion in the public, and it fueled the debate about this is the so-called epidemic of tests. Of course, there was more tests by hospitalization, but it's just simply because people don't get the difference between observable and what is happening underneath. And of course, if we look at those same plots now, we see that things completely change, and the magnitude of the rise in cases that we've seen recently is really apparent from this slide here, because they had to rescale the y-axis. So now the first wave looks like a little bump in this plot compared to the number of cases we have today. And yet last week, the case definition changed again. Because now the asymptomatic will not be tested. So we are going to see a reduction in the number of cases, but we will not know if it is because the transmission is going slower or if it is because we're testing less. And that's making things very, very tricky in the next couple of weeks. But nevertheless, we still have our signal of hospitalization that remains quite common and comparable. And that's why hospitalization has remained a signal that we kept following throughout the entire epidemic, because it's not influenced by the case definition in the same way. Another very important unshared understanding, and for me this is really important because it explains a lot of the kind of surprise people have now by saying we have been taken by surprise. We are not used in our daily life to be exposed to something that grows exponentially. So this visual, I think it's a very nice visual. It shows you the effect of a doubling of the number of rice grains every time you move from one of the box to the next. When you move from 1 to 2 to 4 to 8 to 16 to 32 to 64, etc. And when you simply see this and you imagine these are cases, you can see why we seem to be taken up by surprise. We don't have this kind of mental capacity to understand and to fully capture how massive an exponential growth can be, and how important it is to take an exponential growth at the start, at the time when things are not too late. And there's another excellent visualization that circulated through the social media several months ago, which is this one that shows, what happens when you have a process of contagion. Of course, on the left part of this diagram, you have someone infecting a few other people, and as you move right, you have more and more people infected. When you see this diagram and you ask anyone, where is it best to act? Anyone would say, yeah, it's best to act to the left-hand side of this diagram, because your early actions benefit is going to be multiplicative. So by preventing a few cases in the beginning, you're in fact preventing hundreds, if not thousands, of transmission down the transmission line. But the problem that we have is that because people don't have this shared understanding, they consider that intervention at this point is completely unnecessary. Why worrying of 3 cases at this point in time? It seems completely out of proportion compared to the impact of the disease at that time. But it is only if you have in the back of your mind this notion that few cases, as long as they grow, can lead to a very, very high number of cases down the transmission line. If you don't have this in the back of your mind, you don't see why it matters so much to prevent transmission when it is at a low level. And this is a big failure of all communication as scientists. We have failed to explain this properly to society so that the preventive measure that we were trying to implement in July, August, and early September would be well understood by society. What we were recommending was not well understood and was seen as being completely out of proportion in relation to the level of the transmission at the time. So, and this misunderstanding of the nature of contagion and exponential growth, it's very difficult to communicate it. Another example, if the doubling time is a week, the last week count as much as the entire previous period. This is obvious if you work in the field, not obvious if you're not. And the way you represent things also has some influence. So during the first wave, I was representing all the statistics on the log scale. And then I was being criticized because I was saying, hey, you're minimizing the problem with your scale. You're not showing how the magnitude of the problem. And then some other people took other options. There was someone else who was using Twitter to communicate about things. And then he was criticized because, well, if you show those data in this way, we cannot really see how fast it's going to spread. We cannot see it coming. We are taking up by speed. So the reality is that there's not one way that is better than the other. Both are necessary, but it's difficult to communicate this exponential nature of contagions. Another aspect that is really not well known is this confusion that there is between what I call speed and acceleration. So this is a plot of the number of daily cases per 100,000 people. And this plot was taken late August. And if you look at this plot, it is a speed, because by definition, what you have as a measure is the number of cases per day. So it's the number of events divided by time. So your acceleration is the growth in cases per day. So it's the derivative of your number of events per day. And in fact, it's the slope of those lines that you could fit to your curve at different point in time. So if your epidemic is increasing, your slope is positive. If your epidemic is stable, your slope is equal to 0. And if your epidemic is declining, your slope is negative. And what is very important to understand is that all the different measures we're taking, what we call non-pharmaceutical measures, like social distancing, like the rules on the number of contacts per week, etc., they have an impact on the acceleration. They have an indirect impact on speed, but only through acceleration, because they modify the average number of infection per infected person. So why does it matter? It matters because the measure that you need to take are independent on the level where you are. So imagine this is a situation where we were sometime in, let's say in June. There was very few deaths per day, and we were at a low level of transmission. And then there was some criticism to say, you know, the French expression is le risque zéro n'existe pas. You know, you can't live with a zero risk, in other words. So the measures that we're taking at the moment are an over reaction in relation to the number of deaths we're having at the moment. And that, of course, it's a statement that speaks to the common sense, but that's where common sense fails us. And the reason is the following. imagine that you were prepared to accept a high number of deaths per day. Say, as a society, we decide, okay, we don't want to stay at this level because it has an economic impact that is too high, and we are prepared to accept 50 deaths per day. But the thing is that you will have to stabilize your number of infection to stay at the same level at 50 deaths per day. But to stabilize that, your acceleration must be 0, or otherwise your growth rate should be equal to 1. So what it means that the non-pharmaceutical measures that you need to take, all the social measures, etc., needs to be identical, are going to be identical if you want to stay at a low level or at a high level. So why letting your epidemic go at a high level if by the end of the day you have to take the same kind of measures? So why not try to maintain them at a low level? And that's really where, again, where the lack of understanding of what is a contagious process fails the common sense. And that's where we should try to better explain what is at stake. Another lack of shared understanding is that in the public, in policymakers, in the media, there's lots of the time no familiarity with basic notions of what is sampling. This is an example, and it's an example I discussed with my students even in biostatistics. This is a plot from Sciensano website, and it shows how the positivity rate has been increasing over time since June. So the positivity rate is the number of positive tests within people who got tested. And I asked the question to my class in the biostatistic course, if this, given those data, and given that the people who are tested are either sick or they're high-risk contact or returning travelers, if you have crossed 100 people in the street last week, how many positive people do you think you have met or you have been exposed to? And even though within the biology student, and they've already had a first course in biostatistics, the majority of them said 12.7%. And the majority of them didn't get the point that this was a subset of the entire population and that it was not a random sample, so that this number that we have here is an overestimate of the actual proportion of people who are infected at any point in time. So, and this is in a biology class, and biology and bioengineer class, it's not in the lay audience. So lots of the numbers that people have received, whether they're politicians, journalists, etc., it's not something people are necessarily familiar to handle. And you have, when you communicate, to take that into account. And this is another consequence of this lack of shared understanding. And this is more with the policy makers, with politicians. One thing I've had many times is that they tend to believe what they can understand. And one example is this reproduction number. It is a very useful concept to epidemiologists, but it's complex to estimate. So we've had this dialogue many times, like, as an epidemiologist, we would say, this effective reproduction number, it's very simple. It's the average number of people infected by each infected person on average. And then, yeah, but how do you calculate it? And then you would have to admit that, okay, it's complicated. There are a few assumptions behind its calculation, etc. And then, of course, Sciensano was having their estimate, and the team of Neil Hens had a different estimate. And given the political importance that this number was starting to have, politicians starting to pay a lot more attention to that number. But then they were starting to question, if people have different assumptions, why do we have different numbers? Why is Cienciano reporting different numbers than you, etc.? So this was undermining the credibility of it to a large extent. So keeping relatively simple metrics is that politicians can understand is something definitely useful in communicating with them. And there's the same about a kind of misunderstanding on the nature of what predictive modeling can do with the course of an epidemic. So you've probably have had some of those plots or some of those models from Neil Hens last week. This one was produced by Nicolas Franco from his both at the University of Namur and Hasselt. Many people, including politicians, would take those as actual predictions. Whereas in fact, those kind of long-term model, they are useful in comparing scenarios, but there are so many uncertainties in this system that it's actually very difficult to make accurate real predictions or projections. So it's very important to communicate about the uncertainties that goes with those models, and that you can only use those models to choose between different sets of scenarios with knowing what has been the input of the model. But there's lots of misunderstanding on the nature of that. And then, of course, the last problems I'd like to raise is the fact of being challenged by armchair epidemiologists, as I would call them, and we've been challenged by that many times. Even recently, there was many people working in the medical domain, doctors, etc., saying, this is not worse than the flu. And still, and as much as this is something for which you could understand some kind of uncertainty in the early stage of the epidemics, when there was only data from China and you could have question marks about the real denominator, etc. But no, we have more and more robust data on that. So this, for example, shows in blue, you have the infectious fatality rate for seasonal influenza, and in red, the infection fatality rate for COVID-19. And each line report the result of a different study, and this is primarily for the US. And as you can see, there is, of course, a bit of variation between the study, but most studies seem to converge on the fact that there is that it is worse than the flu in terms of fatality rates, whatever the age class. And when you increase the age class, this becomes more and more strong. But still, in the media, someone saying this is not worse than the flu to justify a statement toward the relaxation of measure, it spreads like wildfire in the social media, because it's what people want to hear, want to understand. It's what people wants to follow, because it's a convenient truth. But we've been challenged by armchair epidemiologists in both ways. Sometimes, someone doing one model was doing a model that looked very frightening, and it gets publicized in such a way and picked up by the media. And sometimes you had some public opinion article like this one that was really shooting at simply a plot that was made where there was a very simple extrapolation. But here, the media who published that opinion had a strong responsibility, because it was not adding anything to the debate in this case. It was simply a very, a very easy critique at Cienciano, but very harsh in the way it was expressed. In French, it was incompétence ou prostitution de la science. Those are very strong words to describe scientists who are trying to do their best. but it is still, it is spreading some, kind of denialism or spreading critique about what is being told to the people, and it's spreading doubt. And then I was exposed only a few weeks ago myself. I was interviewed on RTL, and this was my statement. It was, we need to understand that an exponential growth, even if things are doubling every week or every 2 weeks, in 1 month, you can go from a very small number to a very high number, and we need to anticipate based on that understanding. And that was my statement. And then in the show that there was 30 minutes later, this statement was criticized as saying, it's incredible that an epidemiologist could say something like that. And anything, and so my statement was completely washed out in terms of anticipation by this other statement, and creating big confusion in the public, because from the public's opinion, it is one scientist against the other. They don't have this epidemiological background, they don't have this shared understanding, and then it is seen as being, one scientist against the other. Who is right? I don't know. So in doubt, I would simply follow what is more convenient, and I would probably do nothing about in terms of prevention. And finally, you are exposed to lots of abusive generalization based on personal observation. We've had many times this in the discussion with politicians, even with medical doctors, making statements like, yeah, the situation is under control in my hospital, or I work in a lab, most of our samples are negative, or from one politician, I call the hospital in my municipality, everything is fine there, why should we take measure? Or even very, very recently, the number of deaths is currently very low, why should we do anything about the future? So we should never underestimate the weight of those personal observations in people's belief, including at the highest level. And those statements are not wrong. They're all based on right observation, but simply they make this an abusive generalization that what they observe in their hospital, in their lab, in their municipality applies in different location or in different time. And it's a very abusive generalization that we have to fight with data and evidences. So how can we work on those challenges? Sorry, I'm just checking on times to see where, okay. How could we address all those challenges? My own conclusions based on those months of interactions in this context. First, it has been to try to work on the basis of observables that everyone can have access to, that speak to everyone, and that are relatively constant in terms of how they are observed over time in region. And based on that, I was recommending to use hospitalization because that speaks to everyone. B, try to use simple indicators that everyone can calculate. Even a politician can take the number in Excel and with a little bit of maths can calculate the same indicators as you. Try to have one indicator for speed and one for acceleration, because both are important and both needs to be always communicated simultaneously. Try to use very simple models for projections, because again, when models are not understood, they're not believed. And finally, try to communicate about uncertainties. And this is how we've been trying to develop the barometer. That was this kind of initial attempt at defining different indicators to define different areas. So the barometer was really centered on the number of new hospitalization per 100,000 people. So you can look at the bottom left plot for Belgium. because this is an indicator that very few people can contest. And the left-hand diagram here shows you how the speed is evolving, so the number of new hospitalizations per day. And the two right-hand plots are, in one hand, what I call the daily ratio. So it is the factor by which you need to multiply the numbers of today to have the number of new hospitalization of tomorrow. So at the moment, it is of 1.09. So if you've had, say, 100 new hospitalization today, you would have 109 new hospitalization tomorrow, and then you multiply by 1.09 the day after, and this forth. And then there is this reproductive, effective reproduction number here, because it's used a lot internationally. But as you can see, those two indicators of acceleration, they're really, really parallel. They show very similar features. And this daily ratio is estimated in a very simple way that anyone can reproduce in Excel. You take the last 14 days of data, you make a linear regression, you log transform them to linearize the relationship. You take a linear regression of that, and then you have a slope, you back transform it, and you have your number. And this number, based on this number, you can make projections, because you can start from the number of today and simply multiply it by this number seven times, and then you have your projections 7 days from now. And that's the numbers that we have for Belgium and different provinces. So you have all of those numbers for the incidence, and the projection for the incidence 7 days later or 14 days later. But this is simply based on the assumption that the growth that we're going to see in the next 7 or 14 days is identical to the growth that we've had in the last 14 days. It makes no assumption on the effect of the measures. So we hope that the measures that have been taken in the last 2 weeks will slow things down, and that things will be better than what those projections suggest. And this is the same for hospitalizations. So we have the current level of hospitalization and the projected values for 7 days ahead of us. And as has been highlighted in the media, those figures are particularly worrying for 3 main provinces, Liège, Hainaut, and Brussels, and I barely dared showing the 14 days projections. So we really hope that what we're going to have, that the measures that were taken are going to have the effect. So just before concluding, this is my last slide. Again, I wanted to highlight that in communication, we should never underestimate the weight of personal experience. And that really, I found it really striking that you really have to work hard to go against what seems to be common sense, but that is not common sense, and to go against what people perceive in their direct neighborhood. Even the Prime Minister, you know, many times she was referring to what was happening with her children, with her friends, in order to base judgment without always realizing how limited that could be in terms of information. And finally, you know, a crash course in epidemiology to decision makers and journalists. I really think that we should do that. We should organize that, you know, even if their time is precious. I think that this would be a very, very good investment in the proper handling of the crisis in the future, is for all decision makers to have a crash course in epidemiology so that they understand the nature of contagious processes and how those numbers matter and what you should look at if you want to make proper recommendation and take good measures. And with this, I think I'm at the end of this presentation. Thank you.
Well, thank you very much, Marius. Been wonderful. You are indeed, you know, people might say that the crash course in epidemiology is a bit of a pro domo plea, but you know, you would be a wonderful teacher. for everybody. So that I think it's and what you said is full of wisdom and explained very simply, but some very deep insights. Let me directly give the floor to Hilde for the question. Just one comment. As economists, we are always worried about incentives. One thing I would add to your presentation is that some people prefer not to believe what you're saying, not because they think it's not true, but because it's not in their interest. So I think one of the problem of persuasion is that people have underlying incentives. But let me quickly switch to Hilde. Thank you.
And thank you also for showing us how important scientific communication is, not only towards colleagues, but especially to the lay public. Thank you. We have a question from Claude Sagerman, and I understood that Michel will remark on this, asking the percentage of asymptomatic people and Michel wanted to comment and ask also a question on this.
I don't have the latest figure in mind, because the figure I had in mind dates back to quite a long time ago. Michel, do you have those
yes,
numbers?
First of all, obviously, I want also to thank you warmly. We know how busy you are at this time, and really you took the time to prepare and to give this seminar. Thank you very much. For us, it's very important. And I think for all those who are following you in the media, we could wonder, why is this guy so influential? And I think the answer was given today, because everything you are saying is based on science. And I think that we are hearing too many people who are just giving opinion, which are not really based on science and on research, which is your case. So thank you so much for this. Regarding the question, widely speaking, probably it's about 40% of people infected with the SARS-CoV-2 virus who will not develop symptoms. Now, it's important to realize that when we talk about asymptomatics globally, we should also include people who are asymptomatic at the time of
that's the difficulty
of the visit, and they become symptomatic later. So they should be considered as pre-symptomatic. So anyway, the proportion is huge. And my question to you is the following. We know, since the work of Robert Koch at the beginning of the century, that to fight an epidemic, a pandemic, you have to isolate those who harbor the microbe. It has been very well shown, as you know, with the typhoid fever pandemics. And I was really surprised when I heard the Minister of Health explaining that, sorry guys, but for a few weeks, we will not detect symptomatics anymore. We understand why, because the system was completely overwhelmed, the system of RT-PCR testing. However, as you know, there are a new generation of tests, the rapid antigenic tests, which are now developed widely across Europe. We understand that it can take some time, but when he mentioned that we will need several weeks, that's just unbelievable, because I can tell you that just to order this test will already take a few weeks. So better to start to prepare ourselves now, especially that we will need the collaboration of the GPs and other health professionals to implement the strategy. So could you tell us whether this has been considered? Because from an epidemiological point of view, it seems like a nonsense.
I fully agree. My take on this is that, I mean, the only rationale that I can see for that was this limitation. And then they had to decide, you know, where do we put the focus? And when it comes to the rapid test, I'm frankly in favor of it, because the benefit of having a rapid information for the people who are positive, and we know that the specificity of the test is very good. So if people are positive, well, you know, they would be much more convinced to isolate themselves properly. rather than staying, 3 days without knowing, and during which time, unless they're very, for those who are sick, it's a bit more easy. But for those who are, high risk contact, they probably won't do anything about it. So the benefit of that would certainly counterpart, the lack of sensitivity, and even the lack of sensitivity. I think there's no real problem with that, because you could combine them. You could do, a rapid test, and if negative, you go for the PCR one, and then you combine the advantage of both, and you don't do the PCR if the antigenic test is positive, and that's it. And you could, in that way, you could save a lot of PCR, because if for all those who are positive, you save a PCR, and you could combine the advantage of the two tests in term of timing. So I don't really see why they are authorities are hesitating on that front, frankly.
Thank you.
We have a lot of questions coming in. The first one was from Professor Philippe Verwin from ULB, asking actually about the source. Did it jump from humans by eating animals, by contact with blood, by being bitten by an animal, or by another way of transmission? And is this due to the destruction of the habitat of animals and its encroaching of the habitat by humans?
Yeah, we don't know how the species jump was made, and I don't know we know from molecular evidences that there was this passage that was done from one species to another, and there was all those this link with the pangolin at a certain point in time. It's hard to tell. The thing is that in China, the amount of interface is big in those what we call wet markets, because they call it wet market. It is those markets where you have lots of different meat for multiple species, and you also have live animals. Because culturally, and I know this for avian influenza much better, because I've visited many of those wet markets many times. Culturally, there is, and they have inherited that for a time when there wasn't, all the cold chain, and where people prefer to buy their poultry alive rather than buying meat. People still were buying live animals, and so when you have an infection that is potentially zoonotic, so that can infect human. This is a very, very big interface, and this is one of the reasons why China has now banned those wet markets, especially if they involve wild species, because they want to prevent this to happen again. But what we also know from our experience on avian influenza is that even when they banned the live poultry markets in lots of cities in the context of H7N9, there was lots of markets that were hidden, that were happening elsewhere. So you do not change a society like this. So I think the risk is still there, but the exposure is massive. There has been some surveys that were done in the people who work in those markets, and they found antibodies to lots of avian influenza viruses of all kinds. So clearly the chances of having those jumps, because they multiplied many times, even if they are rare events involving rare mutations, by the multiplicity of the places where those things are happening, you create conditions where by the end of the day they can happen. So that's the only comment I can do about this.
Okay, and then we got a question from Bruno van Pottelsbergen. He will ask it live.
Yes, thank you very much. Very interesting presentation. I was wondering to look at part of your job in March, April, when you were focusing more on communication, whether at some point you felt control in what you were saying publicly due to your role as advisor to the government, and in particular with respect to the masks. I remember in February, March, we were advised to cough on our elbow, and that was the main, I would say, recommendation, and nobody was talking about masks, whereas in many countries, masks were I would say, the priority, and I was always wondering whether this recommendation was driven by the fact that we had no mask in Belgium, and so we had to find an alternative, but it was not told to the public. Maybe you have a better information than me on that.
Yeah, what I can tell is that those decisions and recommendations were done much before we were in the GIS. But clearly, my understanding is, especially given the fact that even people working in nursing homes, and people in the field of health in generally were not always, the use of masks were not always warranted. It was more a question of availability than evidence. I can see well, it's not 100% true. We've seen that the consensus regarding the role of aerosol has been changing over time. If you were to position the consensus on the role of aerosol on the transmission, it was really not a large consensus in the early stage of the epidemic. And as you know, it makes a big difference with regard to the benefits of the use of masks. Even within WHO, the consensus was not there regarding the transmission through aerosols. So I think that, I can only imagine that the Public Health Authority at the time, they saw that there was a shortage of masks, and that so that the benefit of the mask would be higher in protecting your health staff and in conditions where there could be a massive aerosolization through the medical acts, like intubating patients and things like that. And though that they prefer to restrict the use of those masks to people who were presumably the most exposed through their professional activities in hospital or nursing homes, and that this played a role in the decision. So I think there was two factors. That the consensus was not yet 100% there regarding the role of aerosols, combined with the shortage of masks to be provided to the general population.
Thank you.
Thank you. And then Michael wanted to ask you a question. Michael?
Yes. First of all, thank you very much for this amazing presentation. I guess I would be qualified an armchair epidemiologist because I'm an economist. One of the things that we do.
But it's not. I didn't mean to.
No. I don't take it badly. I just mean a joke here.
I don't mean to undermine.
So yes. Go ahead.
No, just what I wanted to say is that for me, the problem is not so much that there is this discussion between scientists. The problem is when this discussion between scientists takes place in the media, because if this discussion takes place within the context of scientific conferences or scientific seminars and things like that, science works like that. Science works by contradiction. Science works by exposing ideas to each other. But when lots of different conflicting ideas, even sometimes when they're very, let's say, poorly supported, comes through the media, then it really have a strong impact on people's understanding, and it creates lots of confusion. So that's just a clarification I wanted to make.
No, but again, I meant it more as a small joke at the beginning, but also as a word of caution. I want to ask a question here, using the same kind of figures that you were showing us. But I need to share my screen for this. So I think we all have seen the important difference in color between the two sides of the linguistic border. So what we've done with Glenn Macherman, who is at ULB like me, is to select the municipalities here along the border, okay?
Yeah.
And in a sense, the question is, can we move from real-time epidemiology to real-time policy learning? And for this, I just want to show, this is the infection. So we took these municipalities only, and we count the number of infections per day, okay? And we have the cumulative here in levels. And here we have a zoom from June onwards in log scale. Okay, I guess I don't need to explain anything about log scales anymore. So the interesting thing, as you saw first, Flanders was more hardly hit in the first phase, and we see that in July it grew faster. Okay, and I see a kink here, which coincides with Antwerp having to shut down. Its activities. And here we are talking about the effect of the information on this on people who don't live in Antwerp, right? Because we are talking about all the linguistic border, just the municipalities north of it. And Wallonia was doing quite well before that, okay? Basically no infection along the linguistic border for months. And the second thing we see here is a kink when schools have started, which did not appear in Flanders. So the question here is, why don't we use this kind? Because the politicians, as you say, they don't know how to use these numbers, etc. But we don't feed them a lot with policy learnings. And we hear the criticism about why should you close bars? We don't have scientific evidence about infections in bars. But we do have plenty of these policy experiments in Belgium and other countries with small policy changes for towns which are just next to each other. And we can actually see stuff happening. So why don't we use this? And how can we use this to learn about the right measures versus the measures which are useless?
Yeah, I mean, for me, you preaching with a convinced person. You know, for me, what you're showing here is, for me, the best example of why all of those data, you know, even the detailed ones, should go in the public, because it's only when they become public that, you know, lots of people who have their own expertise can feed the scientific debate through, and that's why we organize also this scientific conference in September, because we wanted to have this scientific debate, because that's how you can gain understanding. One of the things that happened also is that many of the scientists who were involved in those expert committees, they had little time to do lots of work. And the same for people from Cienzano. So having the help and a positive and constructive discussion with lots of other epidemiologists would be extremely useful to identify exactly what you described, different analysis in different locations that could shed some light on specific aspects of the transmission, and that could help supporting some hypotheses about the effect of one measure against the other. And another element is that, and that's a challenge to epidemiology in general, is the fact that you have lots of coinciding factors. And you always need lots of different situations in order to be able to isolate the effect of one factor or on the other. Because we know that, for example, when it comes to this Flanders versus Wallonia cultural difference, it's obvious from those maps that it is cultural, that it has something to do with something that was taken up differently in Flanders and Wallonia. Otherwise, you wouldn't see a political border, because the testing scheme is the same.
So this is where I beg to differ. We take cities that share the same space.
I agree.
They have the same size, just along the border. And it's really about the measures. And you see that in the first wave, Flanders, these municipalities in the Flemish side were worse hit.
Yeah.
And so if it was just culture, it would have been the same in both events.
Well, I would a bit disagree with that, because for example, what we see is that the denialism has been much more shared in the Francophone cultural life than in Flanders. In Flanders, the criticism of the measure has been mostly led by Lieven Annemans, who is an economist. and his influence in the public opinion has been somewhat buffered by the editorialists of the main journals, who were generally quite supportive of the measures. In Wallonia, it has been quite different. The nihilism has been pushed by people who were from the medical world, with all the credibility of, you know, I'm a doctor from a hospital, I know what I'm talking about. And the influence it had on people's cautiousness has been, I think, I mean, I don't want to blame, you know, it's multifactorial, it's difficult to isolate, but I think there is also a difference from that aspect that could also explain some of those differences between Wallonia and Flanders, because I think that this discourse has had more influence. And also, don't forget Liège, also, where the discourse was also, the septic discourse was also very, very strong. And that has been a very, very fast rise in case and hospitalization as well. So, of course, all of those factors are difficult to disentangle from each others, but there's lots of things happening at the same time. And that's why separating them out is very difficult retrospectively.
Many thanks.
Okay,
maybe a quick...
So maybe, well, I must say it's already 1 minute to 2. And Marius told me that he really had to leave pretty close to 2 o'clock. So maybe we should, and I'm sure there are other questions, but I guess we can also channel some of the questions to you, Marius, so that
Sure.
you could possibly answer when you are available. But so I just wanted to thank you so much for a wonderful talk. I think that this has been great. I thought also Michael's point were quite interesting also. My take of this is that it's not, and I guess that was a bit what you said, Marius, culture somehow is kind of a long run, and therefore cannot explain these differences over a short period of time. On the other hand, I think the media is part of the culture, and I do think that can evolve over time. Frankly, one thing which has always struck me in the media discussions and all that is how volatile the view of the epidemic has been. You know, at the beginning, before the first lockdown, so many people were in denial, small flu and the like. Then all of a sudden, just after 7 deaths, we go for a full lockdown and everybody panics. Then indeed people get tired. From early May in the Gs, it was difficult to slow down the reopening because people thought, oh my God, things are improving. What are you doing, you doomsayers? And then the numbers were indeed surprisingly good. And then at some point in July, they started the rebound. I think was surprising too. And boom, Televal pushed on the brakes, and the politicians followed. So and it worked. But still, early September, again denial, and now we are ready for the second wave, unfortunately, which will be unfortunate. So indeed, this is not culture per se, even though in Belgium we always like to talk about culture, North-South and the like, but it's the interaction with what the media is saying. And indeed there is huge volatility also, because, you know, we are all tired and we'd like to wish the virus away, but then it comes back with a vengeance. So
I think one of the factors that we have underestimate maybe and is the effect of seasonality. I think that when we were deconfining, you know, we could count on the effect that we were heading toward the summer, and even if the seasonality factor is only moderate, when it adds to all the other factors, it can create for a same level of social preventive measure, it can make the difference between a decrease and an increase. And I think that, and it is when there was the first wave, it was late February, early March, and then there was the lockdown. And then, as you remember, we had an extraordinary spring, very, very light, etc. And we haven't experienced a true winter and a true autumn with this virus. And I think that maybe we didn't realize it, but we were quite in favorable conditions during the deconfinement and during the summer. And that now we're paying the price of the opposite effect, that as we enter the autumn and the winter, with the fact of living a lot more inside, and the degradation of the level of ventilation that each and everyone has in his own home and in public spaces, that this is having an effect. So I think that may explain some of the difference that we may not have anticipated enough.
I would like to just conclude, thank you, Marius, for this last comment, with saying that the session is recorded and that by tomorrow it will be on YouTube. The link will be spread, and please don't hesitate to spread the link to anyone who might have missed this session. And indeed, we will get the questions together and spread them also to you. Thank you.
Thank you very much. Everyone. Thank you. Bye-bye to everybody. Thank you.
Bye.